Thank you so much for inviting me to speak to you this evening, and thanks to everyone for tuning in. I want to talk about diabetes. So much we have learned, so much more we still need to know. I've worked in diabetes research for over 40 years as a biomedical researcher. I'm currently adjunct professor at Hamad bin Khalifa University Doha, Qatar, working from the UK. I'm also executive director of Glow Vitality Limited, a UK-based startup company producing and selling a dietary supplement, Glucoregulate. I gained my PhD in biochemistry at the University of Oxford in 1982 and thereafter worked at Aston University, University of Essex, University of Warwick in the UK, and finally as Director of Diabetes Research at Hamad bin Khalifa University in Doha, Qatar. Diabetes is a disease characterized by abnormally increased blood glucose and poor control of blood glucose concentration. Typical symptoms of undiagnosed diabetes are excessive hunger, thirst, urination, and tiredness. The key causative features are deficiency of the hormone insulin, as applies to type 1 diabetes, the type of diabetes that is an autoimmune disease, typically developing in childhood, or impaired response of muscle, liver, and adipose or fat tissue to insulin, called insulin resistance, as applies to type 2 diabetes, the type of diabetes that typically develops from the age of 40 but is now being seen in younger people living with obesity. 8% of diabetes in the UK is type 1 and 92% type 2. People at risk of developing type 2 diabetes are those over 40 years old, over 25 if from an Asian, Black, African or Black Caribbean ethnic background, with a close relative with diabetes, parent, brother or sister, overweight or living with obesity or not very physically active, and of Asian, Black African or Black Caribbean ethnic background. Hereditability of type 2 diabetes is 30 to 70%. This means individual risk of type 2 diabetes varies, but very few people are certain to get it. If concerned about your risk of type 2 diabetes, please visit the Diabetes UK Type 2 Diabetes Risk Calculator at the web link shown. Development of type 2 diabetes goes through sequential stages of decline in blood glucose control, from normal glucose control to insulin resistance to prediabetes and diabetes as shown on the slide. There are characteristic changes in fasting glucose, post-meal glucose, and glycated hemoglobin A1C, a marker of persistent change in glucose control. Firstly, normal glucose control applies to about 60% of the population. Fasting and mealtime increase in glucose is low and A1C is 5.6 or less. The first stage in glucose control decline is insulin resistance. Here there are only short-term increases in blood glucose and A1C is normal. This accounts for 20% of the population and may be asymptomatic, perhaps feeling unusual loss of energy. Next, prediabetes is where there's moderate increase in fasting and mealtime glucose and increased A1C as insulin resistance intensifies and mild symptoms similar to diabetes develop. Finally, type 2 diabetes, 8% of the population, with a marked increase in fasting and mealtime glucose and A1C with strong insulin resistance and failure of insulin secreting beta cells of the pancreas. In Qatar, these values of prevalence are approximately doubled. To appreciate what is lost in diabetes, we can consider how the body manages sugar normally, and it's a story about 4 grams of glucose. 4 grams of glucose circulates in the body of a healthy adult person, 1 teaspoonful, a concentration of 4 to 5 millimolar. This concentration is required to supply the brain and other organs with glucose for normal function. Sugar is managed in the body to keep it this way, whether we are sleeping, sitting, running, or fasting. In our bodies, we use carbohydrate, which are complex sugars, for energy. Recommended intake of carbohydrate is 230 grams per day for women and 300 grams per day for men, including only 30 grams of simple sugar, glucose, fructose, or sucrose, which is table sugar. That's about 7 to 8 cubes. This may decrease to 130 to 230 grams of carbohydrate in diabetes to help control blood sugar. The danger of simple sugars is that they overload tissues with glucose, as we will see later. Sugar reserves are stored in the body as glycogen, maintained at 400 grams in the muscle and 100 grams in the liver. 200 grams of glucose is produced per day in the liver by breakdown of stored glycogen, glycogenolysis, and by formation of glucose from other metabolites, lactate, glycerol, and amino acids in the liver and kidneys. This is called gluconeogenesis. How does the body manage sugar? It's not all about insulin. In the pancreas, insulin is secreted by beta cells in response to increased glucose. It facilitates use of glucose by the liver, muscle, and adipose tissue. There is also glucagon, which is secreted by alpha cells. It facilitates glucose production by the liver between meals. And in the intestines, incretins, GIP and GLP-1, secreted by intestinal K and L cells in response to eating foods such as sugar, unsaturated fatty acids, and protein. These incretins potentiate glucose-induced insulin secretion by threefold and increase satiety, or the feeling of being well fed, for appetite control. So let's see how this plays out through the day. Consider waking up before breakfast. Blood glucose concentration is 4 to 5 millimolar. Glycogen stores are 400 grams in muscle, but down to 20 grams in the liver after being used for glycogenolysis in glucose production as we slept. Blood glucose concentration is maintained in the body by making glucose by mainly glycogenolysis in the liver and also gluconeogenesis in the liver and kidneys. Now, what about after meals? Glucose and other sugars are absorbed. Blood glucose concentration may increase to 7.7 millimolar. In the pancreatic beta cells, insulin secretion is increased. This increases use of glucose for glycogen synthesis in muscle, energy for physical activity, and liver. This is energy for storage, and for making and depositing fat in adipose tissue. This is energy storage. In the pancreatic alpha cells, glucagon secretion is decreased, which reduces glucose synthesis in the liver, not required in the post-meal phase. In the intestine, GIP and GLP-1 are secreted. GIP and GLP-1 potentiate pancreatic insulin secretion threefold for improved tissue entry and storage of glucose, and GLP-1 produces satiety for appetite control. This is called the incretin effect. How does glucose mismanagement lead to the development of type 2 diabetes? Well, by the development of insulin resistance. The father of the insulin resistance field is Dr. Ralph DeFronzo, now about 80 years old. He developed the gold standard measure of insulin resistance, the hyperinsulinemic euglycemic clamp technique, in 1979. He defined insulin resistance as a reduced response of muscle, liver, and adipose tissue to insulin, compared with subjects with normal glucose control. Until our recent research, insulin resistance was called a malady without mechanism. No one understood how it develops. It likely reflects the body's response to frequent and persistent exposure to simple, sugar-rich foods and drinks, trying to protect itself from too much glucose use or glycolytic overload. Our new mechanism of insulin resistance is called hexokinase-linked unscheduled glycolysis and glycolytic overload. Hexokinases are enzymes catalyzing the first step of glucose use in the body. They are gate controllers, keeping flow of glucose use to manageable levels, like the wall of the dam controlling use of water in this photo. Hexokinase 2 controls the use of glucose in muscle and adipose tissue, but it is overwhelmed by the high simple sugar content of modern diets. We propose that the damaging effect of high glucose concentration are a consequence of hexokinase-gated increased flux of glucose metabolism without increased glycolytic enzyme activities to accommodate it. That is, more glucose is entering tissues than they can handle. This likely occurs through persistent repeated exposure to high simple sugar consumption, such that glucose levels rarely achieve those of the overnight fasted phase. The hexokinase gated or control of glucose use, like the DAM, is overwhelmed. Now, what are the consequences for glucose control? Impaired glucose use in muscle, liver, and adipose tissue, and overproduction of glucose by the liver. This increases blood glucose concentration. Excessive glucose flowing into K and L cells and appetite-controlling neurons decrease incretin secretion and appetite control. This increases blood glucose and risk of obesity. This is the impaired incretin response. Finally, excessive glucose flowing persistently into pancreatic beta cells eventually leads to their loss of function. This produces the development of type 2 diabetes. And this was the light bulb moment for us. Key advance in understanding, as it explains all experimental and clinical data on insulin resistance and development of type 2 diabetes. We published this in 2 key publications earlier this year. Given this mechanism of insulin resistance, how can we improve the treatment of diabetes? Treatment with insulin, for example, insulin therapy has been available from the 1920s and was a vital step forward in treatment of diabetes, but other treatments are required. Insulin therapy is essential for patients with type 1 diabetes, although it remains difficult to deliver insulin over time in similar quantity to parts of the body as achieved normally. For example, normally 80% of insulin released by the pancreas is taken up into the liver, but not when, of course, insulin is injected under the skin. Insulin is used sparingly in type 2 diabetes to correct severely elevated blood glucose and when other drugs have failed. This is because abnormally high insulin levels are required for treatment of insulin resistance, and prolonged use of high insulin levels may increase risk of weight gain and heart disease. Insulin therapy is not a long-term treatment for insulin resistance. So for type 2 diabetes, other drugs are required. Metformin is an old drug which suppresses abnormal glucose production by the liver, a feature of insulin resistance and type 2 diabetes. It's good but can be poorly tolerated, with 30% of metformin prescriptions not taken. SGLT2 inhibitors, flozins, are newer medications that increase urinary excretion of glucose, and again, adherence to the prescription is a problem. In the USA, only 45% of older patients adhere to use of this medication. Sulfonylureas are older drugs which increase insulin secretion from the pancreas, but in established type 2 diabetes, beta cells produce less insulin, and hence there is less insulin available for secretion. Insulin mimetics are a newer class of drug which improve blood glucose and appetite control by acting as incretins. Examples are semaglutide, sold as Ozempic, and tirzepatide, sold as Mounjaro, recently in the news. Indeed, these are synthetic long and strong-acting incretins. They are also prescribed to treat obesity. Minor adverse effects occur in about 50% of patients, nausea, constipation and vomiting, and major adverse effects in 3% of patients, such as gallbladder disease. There are also DPP-4 inhibitors, the gliptins, which slow the degradation of natural endogenous incretins. Critically, there is no treatment approved to correct insulin resistance. Rather, these drugs treat one consequence of it. Given this mechanism, how can this guide us to avoid insulin resistance? Well, we need to avoid persistent and frequent consumption of food and drinks rich in simple sugars and avoid overnight snacking. Consider this. Mitai Ladoo contains 19 grams of sucrose per ball, and a sweetened can of cola drink contains 33 grams of sucrose. Current per capita consumption of sweetened soft drinks is 6 cans per week in the UK and 10 cans per week in the USA. So from sweetened cola alone, UK citizens are getting about their daily requirement of simple sugar, and US citizens are exceeding it. We can also take regular physical exercise, brisk walking or jogging, particularly after the evening meal, to avoid entering the overnight fasted phase with high glucose levels. In physical exercise, glucose enters the muscle by an efficient insulin-independent mechanism. It decreases blood glucose even in insulin resistance. Current recommendation is to do at least 75 minutes brisk exercise per week. We also have a new dietary supplement that prevents loss of glucose control and corrects insulin resistance, GlucoRegulate. This was optimized in our research and tested in clinical trials in the UK, where it corrected insulin resistance in people living with overweight and obesity. Our mechanism of the damaging effect of glucose also explains the development of vascular complications of diabetes. These occur after 10 to 20 years of diabetes. Diabetic kidney disease, diabetic retinopathy, diabetic neuropathy, and heart disease. They are also a major threat to quality of life and premature mortality. We look forward to the future when GlucoRegulate may one day be evaluated for treatment of these. In conclusion, we now have a mechanism of insulin resistance which explains how a diet rich in simple sugars leads to impaired blood glucose control and increased risk of obesity and diabetes. It also explains the impaired incretin effect, including how a sugar-rich diet increases overeating. It's not just about a sweet tooth. And a dietary supplement, GlucoRegulate, which corrects insulin resistance. Lead investigators in these recent studies have been me and my colleague, Professor Naila Rabbani. We were funded by Qatar Foundation and Qatar University. Please remember the story of the 4 grams of glucose. Thank you so much.